want to thank everyone for everybody for attending. Today, we are lucky to have an amazing speaker, an amazing physician who is part of the North Shore University Health System in the Chicagoland area, affiliated with Rush University, trained at Northwestern University, is the vice president of the North Shore Cancer Research Association, is a practicing medical oncologist at Hematology Oncology of the North Shore. So we're really fortunate to have Dr. Marlon Kleinman give the presentation. Please text your questions. Dr. Kleinman does an amazing job answering the questions. And if there's follow-up questions, please feel comfortable reaching out and sending them in the chat box. So Dr. Kleinman, I'm going to turn it over to you.
Thank you very much, Nirav. And I want to just thank everyone for taking a pause in their busy day. This is a good time to do it while the clinics are happening and we're experiencing patients, and being able to kind of freeze frame ourselves for a while to focus on what we're doing with cancer and personalized medicine. I guess one of the underlying basic questions that we want to answer: what is personalized cancer treatment? Essentially, biomarker-driven therapy decisions have replaced in medical oncology the former empiric decisions that we used to make. Using comprehensive genomic profiling to identify driver alterations, which could be used to treat cancer more precisely. And this has gone from lung cancer, which we're focusing a lot on during this discussion, but has gone from lung cancer beyond. Let's see here. So this slide sort of represents what I mean, where genomics has really started to take a role in all of medical oncology, or quite a bit of medical oncology. And this clinician standing here is like all of us in our clinics as we stare out in the masses of our patients. It's like looking at a bunch of umbrellas standing in front of us, and each umbrella represents a different disease state. And each spoke that comes out of each of these umbrellas represents a different pathways that essentially drive the illness, pathways that may make more sensitivity to immunotherapy versus targeted therapy, and pathways that render resistance to various treatments. And these pathways, these targets, these biomarkers have evolved to a point in 2022 where we even have several examples of tumor agnostic approaches, FDA approvals of drugs that, for example, address the NTRK fusions, or some of the immune biomarkers such as MSI or other DNA mismatch repair issues. So you can see here clearly this has gone from lung cancer and beyond. And if we think even in terms of lung cancer per se, this again has evolved from a traditional one-size-fits-all approach to a much more precise approach with so many different presentations within one type of disease or within one histology. It's sort of like when I explain this to patients, I give the ice cream analogy. If it was like, let's say 1922, and you went into an ice cream parlor and you just said, hey, I want ice cream, you'd probably get something that resembles ice cream and everybody would be happy. But in 2022, if you go into an ice cream parlor and you just say to the person on the other side, I'd like ice cream, and they would look at you like you're strange, and they would point to some board or something on an app where you can choose from 50 different flavors of ice cream. And if you persist and say, well, I just want ice cream, there's a lack of communication in 2022. And so it is with malignancy. We have to take our histologic tissue diagnoses and try to understand them on a much more molecular level. And these biomarkers tend to fall into two categories. There's prognostic biomarkers, which is information regarding that renders information or prediction regarding the patient's overall cancer outcome. And then there are predictive powers to these biomarkers that some of these actually become targets for therapy. Now, most of these biomarker targeted mutations, driver mutations, historically and currently are detected through tissue. So a patient gets a tissue diagnosis in the context of, say, lung cancer, and then one of the next immediate steps histologically with that tissue is to then try to understand whether or not it has driver mutations. And we use that tissue as a source of genetic material. But the main point we want to make at this time with this slide is that tissue diagnoses have limitations. There are the so-called QNS, quantity not sufficient, where the tissue is looked at by our pathology colleagues, and they do all the appropriate attempts at biomarker assessment to look for those targets. But there may be not enough tissue or not enough genetic material within the tissue to make any judgment, and we get back this QNS, quantity not sufficient. There can be accessibility issues. It might be related to tumor location. Bone and brain lesions are difficult to get at. Patient may have comorbidities and have therefore risks for invasive procedures. A patient may not agree to a procedure. Tissue also has limitations in terms of heterogeneity, and I'm going to show a couple slides in just a moment to demonstrate that. There are turnaround time issues. It takes a much longer time to yield the information, the biomarker-driven information, and that could impact on length of life, as I will show in a later slide. And then there are, of course, many costs and other multiple resource healthcare service utilization issues when it comes to tissue biopsy. So with regard to tumor heterogeneity, this can happen both spatially at one moment in time or temporally over time. What is a tissue biopsy? A tissue biopsy is a freeze frame of one spot at one moment in space and time. And spatial heterogeneity, as demonstrated over here on the left-hand side of the slide, can occur within a population, meaning that the tumor's underlying genetic motor might be different in different individuals, or even within a person, you could have a different genetic driver in the metastatic clone versus the primary site of disease. Over here in the middle of the slide, this demonstrates tumor heterogeneity within a mass, where it's not just one sheath of homogeneous tissue. You have several populations, and there may be a dominant clone in one part of the mass that may not be represented in other parts of the mass. So therefore, there is tumor heterogeneity even within the mass. And tumor heterogeneity can also occur over time. And what we mean by that is the set of driver mutations that are making this cancer grow and exist at the time of diagnosis might shift, the so-called clonal evolution, at the time of its recurrence. Or another example would be a patient being treated, let's say, with a TKI, a tyrosine kinase inhibitor, and then they have progression of disease based on the development of drug resistance. Clonal evolution and drug resistance are examples of spatial heterogeneity. Here's another way to understand tumor heterogeneity in the setting of PD-L1. Over here on the left-hand side of the slide, we are showing the so-called immune synapse, where the immune system is represented down here by these T cells. These blue cells are cancer cells. Under the diseased pathologic circumstance here on the left, the tumor bears the so-called PD-L1. It's like a mask, and security doesn't recognize it. The evil source puts on this mask and neutralizes the T cell, neutralizes the surveillance immune system, therefore downregulating it, and therefore the tumor thrives at this checkpoint. Therapeutically represented on the right, if we block the PD-L1 either with an anti-PD-L1 or an anti-PD-1 on the immune surveillance side, these are immune checkpoint blockers, then we relieve the immune system's ability to recognize the tumor as being a tumor, and this increases T cell activity and ultimately tumor cell death. Now, what's represented on the right side of the slide, because at this time, the standard way of understanding does a lung cancer or cancer in general express this sort of PD-L1 feature is through histology, is through immunohistochemistry. And if you look over here on the right side of the slide, you will see that there are some stains, and if we base our assessment on that part of the slide, we get a TPS score of about 50% PD-L1 positive. But if you base your assessment in the same biopsy specimen in 1, 2, or 3 in these regions, you get 0%, and therefore we would miss the PD-L1 status. And I just want to add briefly, and we'll talk about this a little later on in our discussion, that one of the ways that Circulogene as a liquid biopsy modality distinguishes itself is that it can detect mRNA in serum, in blood, for PD-L1. What I'm showing here at this point in our discussion is simply the barriers that tissue provides us. And this is basically the rationale why it is that liquid biopsy with its NGS testing or PCR-based testing might help us. What is a liquid biopsy? It is tumor-derived materials detected in blood that can also be seen in other bodily fluids. Some vendors have looked at urine, CSF, bronchial washings, saliva, basically any body fluid. We will focus primarily in our discussion on blood. So imagine you have an alien beast that lands from outer space onto planet Earth and rolls into a local river, and its tentacles emerge and grow into the riverbank. And there is water in this river that's running through it, around it. And because of what's happening about a mile away, there are some scientists that are trying to take water samples to understand this alien beast. Similarly, a cancer, the alien beast, can grow and send its tentacles into blood vessels and surrounding tissue. And similarly, blood rushes literally through and around the tumor, and because of apoptosis, necrosis, secretion, erosion, there is this shedding phenomenon that occurs. And pieces of it, whether it's circulating tumor cells, circulating tumor DNA, shed off of it. And the funny looking scientists in this sort of B-rated science fiction analogy, 1 mile away, is all of us, the clinicians, drawing blood on our patients, trying to understand in the sea of even circulating normal DNA, right? How much of it or what amongst it might be coming from that alien beast, might be coming from the cancer. It's all about the shed. Cell-free DNA is present from normal cells and abnormal cells. And the fraction of the cell-free DNA that is from tumor, we refer to as ctDNA, which is the tumor-derived DNA. And we can leverage to sequence the cancer genome with that material. And that's the basis. Now, some tumors will be higher shedders than others. So for example, small cell lung cancer, colorectal carcinoma tends to shed more, whereas pancreas, thyroid, gliomas tend to shed much less. Shedding also may depend on tumor burden. So higher stages of disease, more bulky disease, heavier tumor burdens with visceral metastases tends to shed more than, let's say, indolent progressing diseases or more nodular areas. This is relevant, in fact, as we consider nowadays the application of liquid biopsy in, let's say, the adjuvant setting versus the metastatic setting. So what are the benefits of liquid biopsy? Well, first, real briefly, just to review, where do we get this information? This is a tube of blood, which is undergoes centrifugation. And as we all recall, the red blood cells fall to the bottom as a pellet, leaving the plasma on top and a white buffy coat in the middle. And in that plasma, we can search for mutations, copy number alterations, gene fusions, DNA methylation, insertions, deletions. These are the things that we're looking for in plasma. And the buffy coat, the one point we'll make here is that this is where germline mutations can be assessed. And I want to add very briefly that Circulogene's platform not only looks for somatic gene mutations in plasma, but they also consider germline mutations that occur that are inherited. So what are the benefits of liquid biopsy? As we demonstrated so far, tumor heterogeneity is captured. We're not relying only on the limitation of the specimen. I want to emphasize, and I'm going to show some data in a moment, that this is complementary. Liquid biopsy does not replace tissue biopsy. It augments it. It makes it better. And I'll show you some data where we're trying to figure out, is liquid biopsy augmenting tissue or is tissue biopsy augmenting liquid? We will see in a moment. So there's a complementary relationship where we're expanding the sensitivity of identifying these actual targets and overcoming the quantity not sufficient issue. Liquid biopsy will show some data about how it can be used to monitor outcomes. There's some interesting data emerging in terms of predicting aggressiveness of tumor biology, disease progression and survival. This high throughput methodology allows simultaneous assessment of multiple targets and can capture clonal evolution or the emergence of resistance. And because of the success that we're seeing with liquid biopsy in the metastatic setting, it's raising interesting questions in lung cancer and beyond about the possibility of monitoring earlier stage patients for recurrence or utilizing this information in adjuvant treatment thoughts. So with regard to its complementary nature, this is a study that was done in non-small cell lung cancer. And there was 8 NCCN guideline sanctioned biomarkers looked at. And in this group of patients, they had both tissue and serum samples available. And if you would look at the tissue first, you would pick up 2/3 of the biomarkers, of these actual biomarkers. And 33% were picked up by serum as an adjunct. But if you flipped the order and you would look at the plasma first, you would find that you'd pick up 87% of these sanctioned biomarkers, these actual biomarkers, and 13% were captured on tissue as an adjunct. So again, the couple points to be made from this type of data. One, we still need tissue, obviously. We need tissue as for a diagnosis, and tissue still does contribute to the overall picture. But what's quite interesting is that liquid biopsy is picking it up even more efficiently, some of these actual biomarkers. And if you juxtapose that idea to the fact that there's a lower turnaround time, that we get this information faster, this is even better, for the patient. So the International Association of Lung Cancer has created a mantra based on this data called Plasma First. And this is another data set that's showing essentially the same thing in non-small cell lung cancer. Now, liquid biopsy can be serialized. That's one of the advantages of liquid biopsy. It's one of the ways that We are all starting to use liquid biopsy in our clinics. And here is some data that also creates rationale. This is a group of non-small cell lung cancer patients, and they were all being given chemoimmunotherapy. And upon progression of disease, a liquid biopsy specimen was obtained. And in this study, 32.5%, about a third of patients, had driver mutations identified that weren't previously identified at the time of diagnosis. So here at the time of progressive disease, in about a third of cases, clonal evolution was demonstrated. And this group of patients were followed even subsequently, and there were 43% overall response rates reported in that group of patients, and they followed them out even farther, showing 75% 5-month median treatment, median survival, median progression-free survival. And so showing really the application of how liquid biopsy, purely just liquid biopsy, can clinically impact treatment decisions. Here's another slide showing how we can use serialization of liquid biopsy as a group of EGFR-addicted metastatic non-small cell lung cancer. This is a short-term example, meaning that these patients were given osimertinib-based therapy, and they were all positive at baseline for circulating tumor DNA. And what was being asked and what was shown is that if at 6 weeks, you would check a liquid biopsy specimen, they were watched whether they cleared their previously positive liquid biopsy versus did not clear their previous positive liquid biopsy. And what you can see in these two curves based on progression-free survival and overall survival, there clearly is a difference between those patients who in fact cleared their liquid biopsy, they became circulating tumor DNA negative by 6 weeks, versus those that did not. This is a little bit longer term study that looked at patients with immunotherapy, patients on Keytruda, and distinguished whether or not at a median time of 26.7 months after, so about 2 years post therapy. So these are longer term survivors here who are doing quite well in immunotherapy. And they are being compared whether their circulating tumor DNA was cleared at that longer time point versus not cleared. And you can see those patients who in fact cleared their DNA remain progression free for quite some time versus those that did not. And this, I believe, raises a very interesting question. Many of us are seeing these long-term lung cancer survivors on continued immunotherapy. And the controversial question is there ever a time that you can stop the Keytruda? The concept of MRD, minimal residual disease. Can we, this is not a question, this is more of a question than an answer at this point. Can we consider utilizing this kind of methodology to select a good performing patient who might be able to hold treatment for a period of time and use that same liquid biopsy platform or minimal residual disease platform as a way to decide when to put them back on therapy, to create this concept of intermittency in treatment as opposed to the continuance until true progression or lack of tolerance. I want to move on now to just talk about the liquid biopsy platform itself. The Circulogene uses its own patented LISA methodology, the linear in situ amplification. And what distinguishes it primarily on the left here, you'll see the standard methods that many companies, many liquid biopsy companies use, where there is a mutation somewhere that is to be extracted from this sea of circulating tumor DNA or cell-free DNA. And there's a several stepped process. There's washing, there's elution, and with each of these steps of filtration, we run the risk. It's actually a known fact that about 50% of the material sort of is lost in the process. And so we're dealing with anywhere from 25 to 50% of the original specimen, and that's what we're using to make our diagnostic intervention, to make our assessment. Now, the Circulogene in situ enrichment is different in that everything takes place in one central vessel. And therefore, 93 to 97% of all the original DNA that goes into the beginning of the process is retained. And it's this idea that Circulogene can retain so much of its original material that allows it to not only detect DNA targets better, but it can also detect RNA. Because in this slide, we are showing, based on maternal fetal data, how the half-life of RNA is so quick that if you have a methodology where you're losing a lot of your genetic material in the process, you won't be able to really have a methodology that can detect both DNA and RNA. Circulogene, because of ELISA technology, is able to amplify both DNA and RNA signals, so we're not throwing away that signal, which may have been in the sample to start with. This ability to look at RNA and DNA allows Circulogene to detect fusions, skipping lesions a bit better, so that we're able to get a bigger kind of picture of these lung cancer patients and patients with other diseases. This just shows a broad listing of the 90 gene panel, the full gene listed over here, copy number variants, fusions that are available with this technology, and also Circulogene reports on MSI and PD-L1, which we're going to talk about in a minute. And then these are the germline hereditary gene mutations that are also picked up by this liquid biopsy platform. So one of the other ways that Circulogene distinguishes itself from other vendors is it has the ability to pick up plasma cell-free RNA from PD-L1. And as I showed in a previous slide, tissue acquisition, the immunohistochemical approach, which is the standard, is fraught with acquisition issues based on spatial tumor heterogeneity. And again, if we look at this part of the slide, you get a TPS score of 50%. If you look at this part of the slide, this is how we're assessing it, you would get 0%. Looking at mRNA has been a way to expand it. And I'm going to show some data that was presented by Dr. Paul Walker about a year ago, a little over a year ago, at ASCO Thoracic Surgery, Thoracic Oncology Symposium, to try to show in this very preliminary way, because I want to sort of preface this data that we're about to show. This is hypothesis generating, single institution, and but it is creating some very interesting questions that need further study. So the Eastern Carolina University group has this patient population that's depicted here. These are all non-small cell lung cancer patients who were plasma PD-L1 positive based on Circulogene's mRNA assay. And one thing to note about this patient subset is that they were very bulky. They had brain mets, bone metastases, poor performance status. And what this Kaplan-Meier curve is basically showing in terms of survival are patients getting immunotherapy versus chemotherapy. And there seems to be a very high p-value and a very significant, about a 62% reduction in mortality in these plasma PD-L1 positive patients who got immunotherapy over chemotherapy. This next slide on the right is the same group who got the immunotherapy, the better performing group because of the treatment, and from the ECU cohort. And we want to compare, or at least show some contrast, if you will, or comparability with the famous Keynote-042 study, which was the Merck trial that looked at patients who were tissue PD-L1 positive. And the same idea, patients who got immunotherapy did better than patients who got chemotherapy. But one of the salient things that I'd like to point out with these two curves is, the median survival here. This is again, a very kind of poor prognostic group of non-small cell lung cancer patients with metastatic stage 4 only disease. Over here, we have more of a selected group in a larger study. And some of these patients, in fact, had stage 3B, inoperable stage 3B disease, along with stage 4, but mostly a PS of 0 to 1, and less symptomatic, less brain mets, less bulky disease. But nevertheless, a 15 to 18 month median overall survival, and very impressively on the right side of the curve, longer term survival rates of 30%, comparable to the more selected Keynote-042 group. This is just a superimposed version of the same of the two studies. The more developed lines come from Keynote-042. These other blue lines in the background are from the ECU group. And only to point out how similar the immunotherapy group did. Again, the ECU group being plasma, PD-L1 positive, the Keynote-042 patients being tissue PD-L1 positive, and also to sort of emphasize the contrast in these two patient subsets, that the chemotherapy experience is quite different. Over here, the ECU group, again, we're a much poorer performance status group, more bulky disease, and as we would expect, therefore, they did not perform as well to chemotherapy. But it's the wide difference between these two lines that, at least from a hypothesis generating standpoint, there may be something here. Now, if we were to do what Merck did, which was to combine inoperable stage 3B and stage 4 together from the ECU cohort. So in other words, this is a combination. This slide represents a combination of inoperable stage 3B and stage 4 patients who were all plasma PD-L1 positive and received Keytruda. Over here, we see a very impressive median overall survival of 20 months. And if you go to the right side of the curve, 50% 3-year overall survivals. If we look and ask the question, does ECOG performance status make a difference in terms of outcome? On the left-hand side, these were all PD-L1 tissue positive patients from the Waterhouse et al. Group. This is the Flatiron Health database. And there, based on tissue, all patients receiving immunotherapy, clearly there was a difference between the better performing ECOG group versus patients with ECOG performance status 2 who had 3-year overall survival of 16%. In contrast, in the ECU, the Eastern Carolina group, it didn't really matter so much whether ECOG performance status was 0 to 1 versus ECOG performance status of 2. You still had in both groups essentially the same outcome of a 30% 3-year overall survival. Now, this next slide asks the interesting question. In Keynote 189, these were patients who were tissue PD-L1 negative. And nevertheless, even though in Keynote 189, these patients did not express tissue PD-L1 evidence, there was a benefit to immunotherapy, 20% 3-year overall survivals versus not having immunotherapy. And so these were, this is essentially the addition of Pembro to chemo in the better performing group versus placebo and chemo alone without the immunotherapy. So certainly when this data came out, it was intriguing that even without evidence of tissue PD-L1, that there was still some sort of benefit. Now, based on this idea, what the ECU cohort did in their study was to take the same patient subset, patients who were tissue negative by Caris, and Circulogene plasma PD-L1 positive, and ask the question, what was the reason? Perhaps, perhaps we don't know that these patients, due to tumor heterogeneity, what their true PD-L1 status is. In the group that was tissue negative PD-L1 positive, there was a 50% 3-year overall survival, which might suggest that this is a better way of selecting, even in a tissue negative group, those patients that are most likely to benefit. Because we have to remember too, and remind ourselves that there's also toxicity to immunotherapy, whether it's pneumonitis or any of the other itises. And so, data like this, again, hypothesis generating, might help us be more selective in choosing a patient subset with tissue and liquid biopsy together that are more likely to benefit from immunotherapy. Now I want to shift gears a little bit with the ECU cohort data and look at inoperable stage 3 patients. As we know, the standard of care in stage 3 non-small cell lung cancer is chemoradiation therapy followed by durvalumab. And this is true regardless of tissue PD-L1 status. And so a lot of this data was based on a lot of this guideline is based on the Pacific trial. And what I'm showing here on the left is just one part of that patient subset. These were the patients who happened to be PD-L1 positive and clearly, without question, adding a durvalumab as a consolidation after chemoradiation therapy has a overall survival benefit. And if you look at the ECU cohort of inoperable stage 3 patients, admittedly a small group, but if you look at them and select out those patients who were PD-L plasma PD-L1 positive, there was up to a 90% 3-year overall survival. That was quite impressive here. And if you looked at those patients who got chemoradiation alone, only 32% overall survival. Again, a hypothesis generating, but data that does seem to suggest that there might be a benefit to using a liquid biopsy platform, such as looking at mRNA expression in the plasma PD-L1 to select out good performing patients. And I want to show a controversial slide on the next to show how this might have a good take-home message, because in the same trial, the Pacific trial, if you look at the tissue PD-L1 negative cohort, there was no survival benefit in those patients, and actually an absolute 8% lowering of the overall survival at 36 months. So this sort of begs a question. I mean, right now the standard of care is we don't really consider the tissue PD-L1 status when we're making that inoperable stage 3 decision about durvalumab. NCCN and others tend to recommend it or consider it. But data such as this might again allow us to select these patients out that are going to more likely do well. And this is especially relevant when we consider things like pneumonitis, or even on the flip side, there are some patients that might be PD-L1 negative tissue-wise, and there is some data to suggest that chemoradiation therapy induces an emergence of PD-L1 expression. So it allows us to sort of capture liquid biopsy and its ability to be serialized, allows us to capture some of that biology so that perhaps we can be a little bit less empiric in terms of our treatment decision. Now, the limitations of this data are well recognized. These are small sample sizes. This is a single institution retrospective study. There is currently continued accruing of data of patients and data looking at plasma cell-free RNA PD-L1 expression as a predictive biomarker, and to look at banked plasma and clinical outcomes in IO treatment in a prospective trial. Narav, are we okay with time?
Yeah, it looks like let's 5 or 10 more minutes. Yeah. And whoever
Okay, no
needs to
problem.
jump off, feel free.
All right, good. So I'm going to go pretty quickly through the next slide set. Up until now, I think what I've established is where we're using liquid biopsy, especially in lung cancer, the most. And I want to take the sort of second half of my remarks to kind of show potential where this can go. And in our group, and I know in other groups, we're looking at utilizing liquid biopsy. We're being exploratory with it to apply it in these other situations. So one of those situations happens to be an adjuvant therapy. This is the classic IALT study that showed that, in fact, there was some benefit to the use of adjuvant chemotherapy in early stages of lung cancer. But as I think everyone would agree, that the rim of benefit is small. So it's a very little benefit. I know it was a very big study. So when it's a big study, even a small rim of benefit is significant. But chemotherapy also has toxicity. Can liquid biopsy be more selective in choosing who we should really treat? Or another way to state that, who we should avoid harm in. This next slide shows an example of what I'm talking about in terms of prevention of harm. This was a group of resected non-small cell lung cancer patients, early staged disease. And what was being assessed is their expression of TP53 along with KRAS. And these 4 graphs represent patients who had both mutations versus one mutation and not the other, versus the circled red graph, which is both of these mutations were in fact present. So the one up here, the both mutations were wild type, so they didn't have the mutation. And the take-home message here, and these are patients that got chemo that didn't do as well, is that the combination of p53 and KRAS may predict for a poorer performing group with adjuvant chemotherapy. Another way that we've actually used liquid biopsy is in the setting of the EGFR addicted patient. Quite often, even at the time with resection specimens, we're getting not such stable information, or we're getting information that's not very quick. And so, as we know, based on the classic Andura study, there's a benefit in anti-EGFR agents in patients who have EGFR addicted non-small cell lung cancer patients. And yes, in our group, if we have a patient who is either tissue negative or tissue unknown for EGFR, and we have a liquid biopsy that shows EGFR positivity, we will use that information in making an adjuvant TKI treatment decision with osimertinib. Now, we recognize, though, as we talk about early stage disease, that as I mentioned earlier, that they shed much less. So, the expectation is still very questionable. But if it's present, even if it's a very small mutation allele frequency, a small concentration of circulating tumor DNA, it's still, because of how powerful this particular target is, at least in our hands, we believe it's actionable. And we will use a liquid biopsy as a reason in the adjuvant setting to consider that type of treatment. Similarly, we have data such as Empower that's looking at the PD-L1 expression and whether or not to use immunotherapy in the adjuvant setting. And this has I believe, a potential application in the adjuvant setting in lung cancer, even if we use liquid biopsy. Here is some prognostic information that we are appreciating in earlier stage patients. This study was actually done as a segue, if you will, to another interesting question, which is taking a high risk, unaffected group of patients, so like smokers, who nowadays we all understand that annual low dose non-contrast CTs of the chest are the standard way to identify pulmonary nodules that that may turn out to be early stage lung cancers, but that's also fraught with the possibility of a high false negative rate, and you undergo a procedure only to find out that the tumor was not tumor. So, is there a way to improve the ability to select out high risk unaffected patients, and find out who more likely will have disease versus not? What this data is doing as a sort of precursor step to subsequent studies looking at testing with liquid biopsy a high risk group is first to ask the question, well, look, I understand in stage 3 or stage 4 disease that having circulating tumor DNA means something in terms of overall survival, or in this case, from recurrence. And if we clump together all 3 stages of early stage, stage 1, 2, and stage 3A, essentially, the patients in this blue line who had low levels of circulating tumor DNA versus high levels of circulating tumor DNA, that there clearly was a freedom from recurrence difference. And even if you isolate this data set out to stage 1 only, there's an impressive difference with a very strong p-value. Suggesting, identifying these patients early, whether they have disease or they are high risk for disease, might make sense. Here is some data to suggest, again, KRAS, which we know is an evil player, and finally we now have drugs that are targeting certain KRAS mutations. These are early stage disease. So what I mentioned about the drug, that's more metastatic disease. But this kind of data is raising a question, both prognostically and predictively, ultimately, that stage 1 patients who have KRAS G612 mutations are associated with the worst prognosis. And it just leaves us with a hypothesis statement that, well, maybe by selecting these patients out with whether it's tissue or liquid, if we identify these patients with either platform, could we define a patient subset who should be studied further in the adjuvant setting with agents that target this particular mutation? Here's an interesting data set. These were all operable stage 3A patients, and both tissue and liquid was obtained at the time of essentially diagnosis before neoadjuvant therapy. They received in this set paclitaxel and nivolumab for 3 cycles. Then a liquid biopsy was repeated. It was serialized. Patients ultimately went on to surgery. A tumor block was assessed at the time of surgery, looking classically for the pathologic CR, and adjuvant therapy was rendered for up to a year with immunotherapy. And again, serialization of liquid biopsy. What was interesting about this data set is shown in this next slide. What's on the far right is patients who responded to neoadjuvant therapy, whether they had a complete response, a partial response, or stability of disease by radiographic imaging, there was no difference really in predicting their outcome. Liquid biopsy was almost equally predictive of their outcome, their survival outcome, as was pathologic CR. So what's impressive in this data set is that in the neoadjuvant setting, and there are now studies being looked at also in breast cancer in the neoadjuvant setting, that there may be some predictability of outcome with the liquid platform, and the combination of the two may be perhaps more advantageous to our patients rather than the standard or the historical looking at pathologic CR alone or pathologic assessment alone. There are some other potential liquid biopsy pieces of information that may be helpful. The STK11 as a resistance to immunotherapy. There are 3 genes that I'll show you very quickly in 3 slides that seem to predict resistance to radiation therapy, whether that means external beam radiation or chemoradiation, or if we're talking about stereotactic body radiation. This is the so-called KEAP1 mutation. The KRAS, which we know is a poor performer in all spaces, also predicts for poorer outcomes in SBRT. And the PIK3CA mutations seem to predict for poorer SBRT outcomes. But potentially, again, these are all potential and hypothesis generating. Should we be looking at these patients more clearly, whether or not how we're applying our adjuvant modalities based on molecular expressions, and I mean that molecular expressions both in tissue as well as in liquid. And I want to kind of end our discussion with a little bit about turnaround time. Turnaround time matters in lung cancer. Every 2.3 minutes, there's a new diagnosis. It's a race against time. And as we all know, this is a multidisciplinary disease. We need our surgeons. We need our radiation doctors. We need our pulmonologists. We need our navigational bronchoscopists. We need our pulmonologists. We need our medical oncologists. We need all of our allied, our PAs, all of our other MAs, all of our allied staff to come together and really make this work for our patients, especially during such an inefficient time to practice medicine. We need to overcome these time barriers, and the rationale, the real rationale to overcome these barriers is shown here in this Canadian experience. The better surviving line here, these are all metastatic non-small cell lung cancer patients who were assessed based on how much time it took to get biomarker-driven information. And the curve on the top, the better surviving curve, were patients whose biomarker information was available to the clinicians less than 30 days versus more than 30 days. And you can see here that this is clearly data that shows that time to this information does in fact matter. And we can extrapolate this conceptually and pare it down to a model that Circulogene tries to promote. That really, we want to go multidisciplinary with this discussion. And this slide really takes it home for the reason why. Because even when the lung cancer is merely suspected, we want to try to get that liquid biopsy at the same time as the tissue. Tissue is essential and foundational for the diagnosis and to provide molecular information. The liquid biopsy tremendously augments and is complementary to that information. So that if on day 1, when that patient gets their biopsy and their blood draw at the same time, that by day 8, which in many of our centers, that's the day we're seeing the patient, that's the day we're sitting in tumor board. And you can imagine having biomarker-driven information by day 8 or 9 in order to make a fully informed treatment decision that may impact our patients. and may also, that timing may actually impact their survival. So I just want to make some concluding remarks. I hope that we've been able to show that contemporary cancer medicine has evolved greatly with an emphasis on biomarker-driven treatment. It's no longer one size fits all. Comprehensive genomic profiling is our mechanism, our tool. Next generation sequencing is a high throughput method to make these discoveries. We've talked about what liquid biopsy is. Circulogene itself has a better catch rate. It's distinguished because it picks up not only DNA, but also RNA, which then allows us to pick up fusions and skipping lesions even better. It's able to look at DNA and RNA largely because of its unique LISA, linear in situ amplification technology, without all the different wash and elution steps. We get complete results, DNA, RNA, and also markers of immunotherapy, both somatic and hereditary information, with about a 1 week to 10-day turnaround time. And also unique in the sense that it can pick up plasma PD-L1, augmenting our understanding of patients who may benefit from immunotherapy. I think what I'll do is I'll stop at this point, Nirav, and we can take questions, discussion.
So please feel free to text your question in the chat box.
So this is David Bull. I actually have a couple questions that were preloaded, but then we also have some in the chat, so we will cover. And I appreciate all the time, Dr. Kleinman. The first question is, would you begin treatment if a liquid biopsy came back with an NCC guideline mutation, or would you wait for the confirmation with the tissue?
So yeah, in 2022, if it's an NCCN biomarker sanctioned, the classic, ALK or EGFR in non-small cell lung cancer, and the tissue was, either pending or QNS or something like that, and I had the biomarker positive in plasma, we would utilize that and start therapy.
And a follow-on question is, sometimes there is discrepancy between the liquid biopsy and the tissue. For example, in tissue or in liquid biopsy, you get an NTRK, but in tissue comes back and it's negative. How would you interpret that at that point? What would be what would you be thinking from a treatment standpoint? So,
I may look in something like that. I may look a little more in terms of the metric. How represented it is in serum. If I assume that it's not represented in tissue, only in serum, I'm leaning in that patient towards utilizing that as a real biomarker. But I probably, in that example, would try to look at the magnitude a little bit more. There is background noise. The lower we go in mutational allele frequencies, or if we look at the magnitude of these things, and but if it's a NCCN biomarker sanctioned one, the quintessential example again would be EGFR, where even if we found a mutational allele frequency of less than 0.1%, which is quite low, we would not write that off as being background noise or due to clonal hematopoiesis, which is one of the reasons for these false positives. We would probably, utilize that as a way of therapy.
Thank you. That's great. Talk about insurance. I mean, there's always this question of, will insurance cover for liquid biopsy and or specifically around the Circulogene test? Can you speak to that?
Part of this, I'll tell you the truth. In our group, we have welcomed industry into our space in general. That's always been a philosophy in our group, and we work very hard to stay objective. But because of that welcoming of industry, we feel that we've gotten access to whether it's therapeutics or whether it's diagnostics. We've gotten more comprehensive access. With that access comes relationships. And so the quick answer is no, we have not had trouble. But But part of the mechanism of reassuring our patients that there really is not going to be issues is utilizing the relationships on an ongoing basis. So, our medical assistants, are on a first name basis with, with people like Narav. And so when issues or questionable issues were to come up, there would be interaction between our staff and representatives of Circulogene. And because of that, we have run into very little, if any. I mean, I can't even think of a situation where there was either a problem, and if there was like the little inkling of a problem, it was certainly resolved in a very reasonable period of time.
Yeah, fantastic. And the last question I have, unless somebody else has one, is there are many liquid biopsy suppliers out there, and we all are aware of that. Is there a certain patient population, or when do you decide that you want to use a Circulogene versus somebody else?
That's a great question. I mean, right now, I mean, we're very exploratory in our group, and so we do find that there are different qualities that different groups have. There's different ways. Like I'll give you an example. Circulogene is an outstanding platform to ask an open-ended question to the sea of information in the blood and say, hey, what mutations do you have? But at the same time, we have other interests in assessing molecular blood assays, for example, in the setting of MRD, minimal residual disease. So, more often than not, as long as we're navigating things with the insurance companies, along with the various vendors, each vendor might have a slight difference. We tend to use more than one vendor. Some of our vendors are more focused on looking at MRD, based on some tissue blood relationship going on over there, and other vendors are looking purely at plasma. But I would say at the end here that we're using Circulogene amongst them largely because of the mRNA and because of the PD-L1 mRNA assay. Those two things, at least on a liquid biopsy basis, I think clearly make Circulogene distinguishable.
Very good. Thank you. Any last words from anybody else? Then I'd like to thank everybody for attending. I will stop the recording now. I will